In the following lecture, I want to highlight some of the things that you should be looking for on the echocardiogram. But first, why are we performing echocardiography in the first place? Well, because we want to make the diagnosis, because we are still trying to figure out why the patient has dilated cardiomyopathy. We want to see how severe its problem is, in which stage of the disease he actually is, and because we're looking for the prognosis, we want to tell the patient how his prognosis is, and finally, because we can get a lot of information from the echocardiogram to determine what the best treatment for the patient is. Now, making the diagnosis is sometimes very simple, but sometimes more difficult. Now, if you take a look at this echocardiogram, I think it's very apparent that he has a dilated left ventricle, that he has an impaired systolic function. But what you should also be looking at is whether or not, for example, this function is global or regional, because that, for example, might pinpoint to an ischemic cause of dilated cardiomyopathy.
It is not always easy to differentiate between ischemic and dilated cardiomyopathy. This is a patient where I would like to show you some aspects which can lead us to the correct etiology of the reduced left ventricular function. You see the ventricle is significantly dilated and hypercontractile. But if we look at the specific segments, we can see that the septum shows less contraction than the posteromedial portion, here basal and here mid portion. We can also see that the septum is thinner and there seems to be echogenic areas within the septum which point more to scar or fibrosis. We will now look at the ventricle in the short axis. And here you see a very similar picture. We see that the septum is thinner, less contractile, and the posterolateral region and the lateral region as well as the inferior region seem to show a better contractile function and are also thicker and less echolucent. So from these aspects, we would assume that the patient has ischemic opposed to dilated cardiomyopathy, but we also need to look at the apical views. So these are the apical views now. Again, we see the dilated left ventricle, which has an end diastolic volume of almost 500 milliliters. So this is a severely dilated left ventricle. And if we again look at the different segments, the segment here, the septum, is less contractile than the posteromedial segments, and the apex, if I just turn the transducer, you will see the apex better, is also less contractile than the remaining myocardium. Of course, it's always difficult, especially in the setting of dysynchrony, to determine if the motion of the septum is really akinetic or if it is just the consequence of dysynchrony. But in this case, I think it's quite apparent that these segments are less contractile. So we can also look at the two-chamber view, and this shows a very similar picture with remaining wall thickness of the inferior wall, even though it is hypokinetic as well, severely hyperkinetic. We have a better contractile function of the basal anterior wall, and we have akinesis of the entire apex and distal and probably mid anterior wall. So in summary, all these findings point more to an ischemic cardiomyopathy. We know the history of the patient. The patient had a very large LAD, very large anterior myocardial infarction caused by a proximal LAD occlusion.
You should also look at the valves, of course, because if you have significant regurgitation and that there is a structural problem of the valve, then the cause of the reduced left ventricular function is not a primary myocardial disease, but it's rather a valvular disease. In other words, for example, significant mitral regurgitation, which eventually led to systolic dysfunction.
It's also important to look at the valves in patients with cardiomyopathy. Let's take a look at the mitral valve. First of all, we can see that the mitral valve does not open the way it usually does, but it has more a myopathic motion caused by the low cardiac output. And if we put the color inside, we see that there is some degree of mitral regurgitation, which is not very significant. We can appreciate that nicely both in the 4 and also in the 2-chamber view, as well as the apical long axis. So there is not much mitral regurgitation in this case, which is an important finding simply because it does show that the patient does not have additional strain on the left ventricle put on because of regurgitation. So there is no additional volume overload, which is an important prognostic factor also in this setting.
But what about this patient? Does this patient have dilated cardiomyopathy? His left ventricle function is impaired, but the ventricle is not really dilated. Well, there are many reasons why the ventricle might not be dilated. For example, if it's in an acute stage of heart failure, the left ventricle might not have time to adapt yet. Or if patients, for example, have hypertrophy of the ventricle because they have hypertensive heart disease, for example, and the ventricle usually does not dilate as much as those patients who do not have hypertensive heart disease. So be aware that there are certain variations. And here are 2 more examples. Compare the 2 echoes. Are they the same? Well, definitely not. The patient on the right has very poor left ventricle function, and on the left side, this patient only has, I would say, mildly reduced left ventricle function. So sometimes you'll see subclinical forms, and these 2 have to be picked up because the earlier we treat these patients, the better the prognosis is. Does this patient have dilated cardiomyopathy? Well, his ventricle is pretty much normal, but function doesn't appear to be completely normal. This is such an example where the diagnosis is sometimes very, very difficult. In this case, I would perform additional imaging techniques. I would, for example, use speckle tracking to look at subclinical dysfunction and also look at lab values such as BNP. And if you're not certain, just follow up on these patients. Sometimes you will see that heart failure develops over time. But now let's go to a patient and see how we actually evaluate a patient with dilated cardiomyopathy.
This is how I would quantify left ventricular function and left ventricular size in a patient with cardiomyopathy. This is the parasternal long axis view, and the first thing that I would recommend to do is always look at the visual assessment of the left ventricle, of the function, and you can do that in this view, but you can also, or you should also do that in the short axis view of the left ventricle, scanning the left ventricle down as far as you can, and also in the apical views. I think it's quite apparent if you look at left ventricular function that it is significantly reduced. This is also true in the 2-chamber view and also in the apical long axis view. Now let's try to quantify the size and the function of the left ventricle. I will now go back to the parasternal long axis, and you would need to perform an M mode, which is quite difficult in this patient because we are not ideal with respect to the axis. But I will try nevertheless to perform an M mode, which is certainly not perpendicular to the septum, just to see which measurement we will get, and we'll have to correlate that with the other measurements. Okay, so this is the end diastolic diameter, somewhere in the range of 91 millimeters. And now we'll do the same thing in systole, and we get an end systolic diameter of 80 millimeters, which amounts to a fractional shortening of 12%, which is approximately what we would assume in this patient. To confirm these measurements, we can now perform just a one-dimensional or just a 2D measurement of the left ventricle, starting from the lateral wall to the septum. And we see that we get a very similar measurement here in the apical view, 86 millimeters. To get a better handle on the size of the left ventricle, it is probably better to perform volume measurements. And the volume measurements can be performed by doing a planimetry of the left ventricle, starting with end diastole. I'll show you this. We would contour the left ventricle and then close the contour at the level of the mitral annulus. And here we got a volume of 426 milliliters for the 4-chamber view. Then we would repeat the measurement also in end systole and calculate the ejection fraction. But we would also perform these measurements here in the 2-chamber view, both in diastole and systole. And in this patient, we actually got an ejection fraction close to 20%, and finally an end diastolic volume of something in the range of 450 milliliters, which is significantly enlarged. So in summary, if we look at this patient, we have a very large left ventricle, and we have a significantly reduced or severely reduced left ventricular function.
Now let's take a look at some diagnostic challenges where the diagnosis is not so easy to be established. One of the most difficult situations, at least in my clinical experience, is to figure out if a patient really has a reduction in left ventricular function if there is dysynchrony, a left bundle branch block. Here's such an example. Now, the problem here is that it's very difficult to define when we actually have systole and diastole because different portions of the myocardium contract at different time points. So it's not even possible to really define when we should calculate the end diastolic or end systolic volumes. In addition, every patient who has a left bundle branch block appears to have a reduction in left ventricular function. Not necessarily contractility, but function is reduced in most patients. Let's take a closer look at this patient here. He has a bundle branch block with a QRS width of 145 milliseconds. Now, if you look at the contractility in this region here, it looks quite normal. But look at the septum. It wiggles back and forth. It has a biphasic motion. And the same is true here in the short axis view. Contractility looks quite normal here, but the septum looks awkward. You might even think that there's a regional wall motion abnormality here. Another differential diagnosis to patients with left bundle branch block. Now, I would think that this function is probably mildly reduced, but don't be surprised that if you could really treat left bundle branch block, for example, with the help of a CRT system, that left ventricular function then looks completely normal. In any case, we're going to have a complete chapter on cardiac resynchronization therapy that is going to cover all of these topics and show you some of the examples and also help you how to assess left ventricular function. Here's another diagnostic challenge. Does this patient have true dilated cardiomyopathy with a diffuse reduction in left ventricular function, or are there segmental wall motion abnormalities which would suggest that the patient has ischemic cardiomyopathy? Look closely. We have the impression that the inferior wall here is hypokinetic. And the same is true for the posterolateral region right here. You see the septum seems to contract better, and so does the anterior wall. Well, let's find out. Here is his coronary angiogram. First, the left coronary artery. All the branches are completely normal. And what about the right coronary artery? Here too, we have a normal coronary angiogram. Now, of course, it does not exclude for 100% that the patient does not have an ischemic cause because maybe he had a thrombotic obstruction which resolved and the coronaries now look normal. But the truth is that in very many patients, we cannot differentiate the two because even dilated cardiomyopathy patients sometimes have segmental wall motion abnormalities because sometimes infection or myocarditis is also segmental. So the problem is that in many patients, we cannot say for sure. Here's another example where we have a diagnostic problem. A patient who has a reduction in left ventricular function, a dilated ventricle as well, and where we also have aortic regurgitation. Well, is aortic regurgitation just an additional incidental finding, or is maybe aortic regurgitation the problem that he has in the first place? Because aortic regurgitation causes left ventricle volume overload, and this volume overload could eventually cause left ventricle dysfunction. So this is sometimes very difficult to differentiate. And it's not only aortic regurgitation that presents a problem. More frequently, it is mitral regurgitation. Here's an example of a patient who has a dilated left ventricle and where we have massive mitral regurgitation, huge flow convergence zone, and an eccentric jet that we probably also underestimate with respect to its severity. Now, in this situation, we could have two possibilities. The first possibility is that the patient has dilated cardiomyopathy and the ventricle dilated, and therefore we have now functional mitral regurgitation. And the other possibility is that the patient has mitral regurgitation, which led to left ventricle dilatation and eventually left heart failure. So it's the chicken and the egg problem. We do not know for sure, but what we can look at is the structure of the mitral valve. And primarily in this situation, we'll be looking whether or not the patient has something like a mitral valve prolapse or a flail leaflet or any structural defect which was there as an original problem leading to mitral regurgitation and then secondary left ventricular dysfunction. The next thing we have to look at is the size and the function of the left ventricle. Now, why is that important? Well, obviously, the bigger the ventricle is and the worse left ventricular function is, the worse his prognosis is. But not always. Be aware that ejection fraction is not such a good parameter to really look at how severe his heart failure is, because you will find patients who have very poor left ventricular function, but who still have a relatively good exercise capacity. Still, it's something that we have to evaluate. And we do that by the means that we presented in the chapter on chambers of the heart. Here's just an example of looking at the size of the left ventricle with the M mode and by calculating fractional shortening, but you'll do, of course, all the parameters that we talked about previously, such as Simpson and eyeballing of left ventricular function. One thing I do want to mention in this chapter is the issue of low cardiac output, because low cardiac output gives you additional information. In many patients who have very poor left ventricular function, will you still have, at least at rest, normal cardiac output. But if you look at this patient here, you will see that his function is not only very bad, but also that the flow across the LVOT is very low. Normally you'll have a flow which is in the region of maybe 0.9 to 1.2 meters per second. Here it is only 0.5 meters per second. And the entire velocity time integral is very low as well. You have a very short duration of systole. This is such an example of a patient who already has forward heart failure. And those are patients who come into a subgroup of patients who have very poor prognosis and also who are usually very symptomatic. You can look at low cardiac output also if you use an M mode, because you will see a typical pattern where you have premature closure of the aortic valve. You see, during systole, there's not enough flow to actually push the aortic valve open, so it closes prematurely. This would be a normal signal here, and this is the situation of low cardiac output. And I think if you look at this ventricle, you can understand why this patient must have low cardiac output. This is very, very poor left ventricular function. And of course, he also has a high heart rate to compensate for this poor left ventricular function as well. Aside from left ventricular function and size, there are other things that you should study in these patients. And this includes left atrial size, diastolic function, because there we'll be assessing filling pressures, and the right ventricle, as you will see later. But now let's focus on the left atrium and look at how we assess the left atrium in such patients.
In patients with cardiomyopathy, it is also important to look at the atria. We will now take a look at the atria and at the size of the atria. I will do this by looking at the 4-chamber view. And in the 2D image, you will see that the atria are not significantly enlarged. We can get an approximation of the size by performing a 2D measurement here from the annulus down to the roof of the left atrium. And you see that the left atrium is actually almost of normal size. To confirm this measurement, I would perform an area measurement of the left atrium. Okay, close the sector here. And we get 26 square centimeters, which just shows that the left atrium is not significantly enlarged and almost of normal size. Now, this is an important finding also in the setting because it does show that the patient is probably not at increased risk of of developing atrial fibrillation, and that it does show that the patient has a good prognosis based on the size of the left atrium.
What about diastolic function? Diastolic function is very important because diastolic function gives us information about filling pressures. And filling pressures are important because they correlate strongly with symptoms and also with the prognosis of the patient. So here are some examples and some very important issues to be aware of. Which of these patients have less symptoms and a better prognosis? The one on the left here or the one on the right? This patient has impaired relaxation. We've got an E wave, which is smaller than the A wave. And this patient has a restrictive filling pattern, a high E wave and a very small A wave, and also a very steep deceleration time. Well, as you know from the chapter on diastolic dysfunction, this patient here definitely has higher filling pressures than this patient here. So it's this patient who has a problem. Now, how do we use this in daily clinical practice? Well, I would use it in every patient. Even though it's just I would say, crude way of looking at filling pressures, it does give you important information on the patient. If you don't have sinus rhythm, you can just look at the steepness of this curve at the deceleration time, and that will also correlate with filling pressures. If you want to find out more about diastolic function, we've got an entire chapter on this issue. Obviously, you're going to look at mitral regurgitation in all patients because it gives you additional very important information. Two examples again. Here on the left, you have a patient who has maybe mild to moderate mitral regurgitation, and here a patient with very severe regurgitation. A broad jet, a lot of flow convergence zone. The jet fills almost the entire left atrium. Now, what are the considerations here? Well, in this patient, we have a high volume overload. In other words, actually, we'd expect the ventricle to be hyperdynamic. So basically, if you look at his function, you have to even subtract some ejection fraction points to understand the true left ventricular function this patient has. This is probably not the case in this patient. So not only does this patient have a worse left ventricular function to start out with, but he also has volume overload. So this is the patient who probably has a much worse prognosis and probably also more symptoms. The other issue that you should look into is the shape and configuration of the ventricle. Now, here's a patient who has a dilated left ventricle. He has dilated cardiomyopathy and he has mitral regurgitation, probably moderate to severe. And now take a look at this patient here. This patient has a ventricle which is actually even larger. It has a very spherical ventricle, but does he have mitral regurgitation? Well, hardly. So the factors that contribute are not only the dimension of the ventricle itself, but more importantly, how wide the ring is. And as you can see in this patient here, the annulus is quite small. There's a bulging of the ventricle right here, but the annulus is small. So the key message here is the size of the ventricle does not always correlate with the degree of mitral regurgitation. It's probably more the size of the annulus. But let's go to a demo and see how we evaluate mitral regurgitation in a patient.
It's also important to look at the valves in patients with cardiomyopathy. Let's take a look at the mitral valve. First of all, we can see that the mitral valve does not open the way it usually does, but it has more a myopathic motion caused by the low cardiac output. And if we put the color inside, we see that there is some degree of mitral regurgitation, which is not very significant. We can appreciate that nicely both in the 4 and also in the 2-chamber view, as well as the apical long axis. So there is not much mitral regurgitation in this case, which is an important finding simply because it does show that the patient does not have additional strain on the left ventricle put on because of regurgitation. So there is no additional volume overload, which is an important prognostic factor also in this setting.
To summarize the key points which influence the severity of mitral regurgitation in these patients, it's the shape of the ventricle, it's the width of the annulus, whether or not we've got tenting or restrictive mitral valve leaflet, ejection fraction itself, afterload, in other words, how high systolic blood pressure is, and whether or not dysynchrony is present. But remember one thing, mitral regurgitation brings the ship of dilated cardiomyopathy to sink. We've talked about the left ventricle, we've talked about the atria, now it's time to look at the right ventricle. Which of these patients do you think is better off? Again, the one on the left here or the one on the right? Now, this patient has a larger left ventricle and maybe even his left ventricle function is worse. But it is the patient who is probably better off. Why? Because he still has a normal-sized right ventricle with normal right ventricle function. This is not the case in this patient. So, if you have patients who have very poor left ventricle function, it's usually the right ventricle which takes the lead with respect to the prognosis. Here's such an example of a patient who has a very poor right ventricle function. You see that we have a dilated right ventricle with almost no contractility left here in the free lateral wall of the right ventricle. And even though the basal wall seems to contract okay here, it's hypokinetic here. So how do we know that his right ventricle function is so poor? To understand, let's take a look at his tricuspid regurgitation and at the tricuspid regurgitant signal. The velocity is very low. Why is that so? Because the right ventricle is not able to generate high pressures anymore. It's failing. There's a forward failure. Now, keep in mind, and this is the key issue I'm trying to make here, once you have a patient who has biventricular heart failure, his prognosis drops dramatically, and he will usually get symptomatic, and he will have things like pleural effusion, which again are a sign of right heart failure. If you have patients with dilated cardiomyopathy, and if you have the suspicion that the right ventricle is failing, look at the pleura and also look at maybe the abdomen to see if ascites is present as well. But now it's time again to go to the patient and see how we assess right ventricle function with echocardiography in these patients.
It is equally important to look at the right ventricle when we look at patients with cardiomyopathy. So we'll start with the four-chamber view and focus to the right ventricle. And you can nicely see that despite the very large left ventricle, the size of the right ventricle is fairly normal. It's actually almost smaller than normal. If we measure the diameter, 25 millimeters. So this is a completely normal right ventricular size. And in the 2D image, you also see that the lateral wall is contracting quite nicely. So this is also normal right ventricular function. This is an important finding in the setting of cardiomyopathy because it very closely correlates with the symptom of the patient. So if the patient still has normal right ventricular function, he is usually still in a fairly good compensated state. Let's also look at tricuspid regurgitation, which is only mild. And we already recorded the tricuspid regurgitation signal, which is this here. And when we quantified pulmonary pressure, we found that the gradient is quite low, 39. So if we estimate right atrial pressure to be somewhere in the range of 10 millimeters mercury, we get maybe a systolic pulmonary pressure of 50 millimeters mercury, which is also not very high.
Aside from the right ventricle, there are other important things to look at as well if you study these patients, and that is pulmonary artery pressure. Now, pulmonary artery pressure is important because it too correlates strongly with the prognosis and also with the symptoms of the patients. And the good thing is that if you look at pulmonary artery pressure, you can monitor patients and see how they react to treatment. To quantify pulmonary artery pressure, we need a TR signal. And basically, we look at the maximum velocity of the TR signal. But we're going to have a specific chapter that's going to deal only with this topic, and there you will learn how to do this in daily clinical practice. At this point, I also want to mention synchrony again, because it's such an important topic in dilated cardiomyopathy. And the role that you have when you perform an echo is to detect whether or not synchrony is present or not. And in most cases, especially if the QRS complex is rather wide, you will be able to just eyeball synchrony. And if you have the suspicion, you should think about CRT as a therapeutic option. And we have a separate chapter that I think you should see, because that will definitely make a difference to your patients. And I have one more important feature to look for: thrombus. Why do patients develop a thrombus? Well, simply because these patients have poor left ventricular function and therefore slow flow, not only in the ventricles, but also in the atria, especially if they also have atrial fibrillation. So you can find a thrombus in the ventricles, but also in the atria. And this is such an example. If you look closely, you will see that this is the left atrial appendage here, that there's a thrombus in the left atrial appendage. Now, of course, normally you would use a transesophageal study to visualize the left atrial appendage, but in this case it was visible as well with transthoracic echo. This is the finding you'll find more frequently, namely a thrombus, in this case a relatively fresh thrombus, which is highly mobile in the left ventricle in a patient who has very poor left ventricular function. Now, in the SOLVE trial, they found that the incidence of thrombus formation is more frequent in females than in males, and it also correlates with the degree of left ventricular dysfunction. No question, if you have very poor left ventricular function, then the risk is probably higher. The role of echo here is but not only in detecting a thrombus, but also in following the thrombus to see if it responds to therapy, to heparin or warfarin, for example. And this is the same patient again. You see that after heparin was initiated, the thrombus completely resolved. So putting all this together, what are the key points that you should remember from this lecture? Don't only look at left ventricular function and size. Also look at the presence of synchrony. Look at diastolic function to determine whether or not filling pressures are elevated. Whether or not mitral regurgitation is present, because it's an additional burden to the ventricle and strongly correlates with the prognosis of the patient. The size of the left atrium, because it more or less dictates the development of atrial fibrillation. Right ventricle function, tricuspid regurgitation, and the degree of pulmonary hypertension. All of this is important in the evaluation of patients with dilated cardiomyopathy.